Hello, I am Professor Sarita Magoo from Rohtak, India. I would like to meet you at Russian Electronic Journal of Radiology. I will be talking on imaging evaluation of neck masses. Palpable neck masses are common indication for imaging. They may be infectious, inflammatory, traumatic, lymphovascular, immunologic or congenital etiologies. Radiological assessment should be tailored based on patient presentation, physical examination and clinical suspicion. The goal of imaging is to arrive at a diagnosis or limited differential in an efficient manner while minimizing radiation exposure. Clinical examination alone does not reliably indicate the true nature and extent of neck lesion. Imaging plays an essential role in the management of neck masses. It allows us to identify true disease versus pseudomasses and to show exact location and extent of a lesion and predict the nature of the lesion. Conventional films can only be used for a preliminary evaluation, especially of the retropharyngeal space when there is a question of retropharyngeal phlegmon or abscess. Ultrasound is useful in differentiating solid from cystic neck lesions, in recording the size of nodes, and in discriminating high flow from low flow vascular malformations. CT gives a greatly improved soft tissue detail and airspace delineation. The vascularity of the lesion as well as its relation to vascular structures can be determined. Entire extent of large masses can be assessed. CT angiography provides non-invasive evaluation of vascular structures of the neck. CT and MRI are best indicated for deep or extensive lesions where para and retropharyngeal spaces are best suspected to be involved and when ultrasonography is inconclusive. MRI is excellent in detection of the lesion and extent of involvement of the adjoining structures. Coming to the anatomy, the neck is composed of the posteriorly located nuca and the anteriorly located cervix. The nuca consists of the vertebral column and its associated musculature. The cervix can be thought of a cylinder whose superior extent is a line connecting the occiput and the tip of the chin and whose inferior extent parallels the course of the first rib at the thoracic inlet. The sternocleidomastoid muscle divides the neck into anterior and posterior cervical triangles. Now coming diagram which shows the division of the anterior triangle and the posterior triangle. The boundaries of the anterior triangle are formed by the mandible superiorly, the midline anteriorly and sternocleidomastoid muscle posteriorly. The suprahyoid portion is divided into the submandibular and submental triangles by anterior belly of the digastric muscle. Major components of the submandibular triangle are submandibular glands and submandibular lymph nodes. Major components of the submental triangle are submental lymph nodes. The inferior portion of the anterior cervical triangle is further divided into the carotid triangle and the muscular triangle by the superior belly of the omohyoid muscle. Major components of the carotid triangle are the common carotid artery, the internal jugular vein, vagus nerve and internal jugular lymph nodes. The muscular triangle contains the larynx, hypopharynx, trachea, esophagus, thyroid, parathyroid glands and the strap muscles. The posterior triangle is defined by the sternocleidomastoid muscle anteriorly and trapezius muscle posteriorly and the clavicle inferiorly. The inferior belly of the omohyoid will further divide it into the occipital triangle and the subclavian triangle. The occipital triangle contains the spinal accessory nerve, cutaneous branches of brachial plexus and lymph nodes. The subclavian triangle contains the subclavian vessels, lymph nodes, portion of the brachial plexus and the phrenic nerve. Spaces located in the suprahyoid neck are the parapharyngeal space, pharyngeal mucal space, parotid space, sublingual space, masticator space, submandibular space, and buccal space. Spaces located in the infrahyoid neck are the visceral space, the anterior cervical space, and the posterior cervical space. Carotid space and retropharyngeal space and prevertebral space are spaces common to both suprahyoid and infrahyoid part of the neck. Now coming to the various common lesions or masses that are seen in the neck, we first come to the thyroglossal duct cyst. The thyroglossal duct cysts are the most common congenital neck cysts and constitute 70% of neck anomalies. 90% of cases present before the age of 10 years. The cysts can occur anywhere along the course of the thyroglossal duct, although infrahyoid location is most common, that is 45%. Suprahyoid is seen in 20 to 25% at the level of the hair bone in 30%. Typically, they are located in the midline in 70% cases, with those of midline characteristically tucked next to the thyroid cartilage. On ultrasound, they are seen as anechoic or homogeneously hypoechoic with internal debris. Majority of them show posterior enhancement. Heterogeneous internal echoes are and septa may be seen when there is inflammation. On CT, they are seen as thin-walled, smooth, well-defined, homogeneously attenuating lesions in an anterior, midline or para-midline location. They demonstrate slight rim enhancement and internal septations, average density being 18 to 20 HU. On MRI, they are seen as low signal intensity lesions on T1 because of the low protein and high signal intensity on T2. Thin peripheral enhancement may be seen. This is a case of a 5-year-old male who presented with painless neck swelling in the left paramedian location of the neck for 4 months. The lesion was found to move with tongue protrusion. On ultrasound, shows a cystic swelling at the infrahyoid level, and the lesion showed movement on tongue protrusion. CT at the level shows a left paramedian hypodense lesion with fluid attenuation. The lesion is embedded in the strap muscles. It's another case of thyroglossal cyst in a 7-year-old female who presented with a painless neck swelling in the left paramedian position of the neck since 3 years, and the lesion was found to move with tongue protrusion. Ultrasound shows a cystic swelling at the infrahyoid level, and the lesion was moving with tongue protrusion. An MRI done, axial T1 weighted images, shows a hypointense lesion in the left paramedian infrahyoid location of the neck. Now we will come to lymphangioma. It accounts for about 5% of all benign tumors in children and usually present in the submandibular space or posterior triangle. On ultrasound, they are seen as ill-defined unilocular to multilocular cystic masses with septae of variable thickness. The cyst wall is irregular and the lesion contains internal echoes in case of infection or hemorrhage. On CT, they appear as unilocular to multilocular, non-enhancing, hypoattenuated masses without significant mass effect that insinuates between normal structures. They show homogeneous fluid attenuation. This is a patient, a 4-year-old male who presented with a large swelling on left side of the neck since birth. Ultrasound shows a cystic lesion with septations and fine internal echoes on left side of the neck. An axial CT at the level shows a hypodense lesion with fluid attenuation and multiple septations in anterior triangle of the neck. The lesion is compressing the airways and insinuating into the tissue planes. Coming to branchial cleft anomalies. Now, 3/4 of these anomalies are cysts and typically occur between 10 and 14 years, in contrast to fistulas or sinuses, which manifest mostly during the first decade of life. 92 to 95% arise from the second cleft, 5 to 8% are from the first branchial cleft, with rare third and fourth branchial cleft anomalies. Typically, second branchial cleft cysts present as a rounded swelling just below the angle of the mandible anterior to the sternocleidomastoid. On ultrasound, second branchial cleft cyst would be seen as an anechoic to homogeneously hypoechoic lesion with internal debris sharply demarcated with thin, imperceptible wall with posterior acoustic enhancement. On CT, they are seen as thin-walled, sharply circumscribed cysts having water density, and septations are uncommon and are usually found in cases of previous infection or after a needle aspiration. On MRI, they show variable signal on T1, high protein content would show high signal, low protein content a low signal, and a high signal intensity on T2. An ultrasound of a patient of a branchial cleft cyst in a 6-year-old female who presented with a painless neck swelling on the right paramedian location of neck for the last 4 months, seen as a cystic swelling with posterior acoustic enhancement in the right anterior cervical region. And a CT done at that level shows a hypodense lesion with fluid attenuation lateral to the carotid muscles and anterior to the sternocleidomastoid. A dermoid cyst occurs anywhere in the body, with 7% presenting as head and neck lesions. They are lined by epithelium and differ from the epidermoid cysts, which contain skin appendages, hair follicles, and sebaceous glands within the cyst wall. On ultrasound, it is seen as a well-defined anechoic mass with posterior enhancement. May show homogeneous internal echos. Heterogeneous appearance may be seen due to the presence of echogenic fat, osseous or dental elements. On CT, it appears as a low-density, unilocular, well-circumscribed mass. Fat mixed density fluid and calcification may also be seen. There may be coalescence of fat into small nodules within the cystic lesion, giving a sac of marbles appearance. This is a patient, a 12-year-old male, who presented with a painless midline swelling of the neck since 8 months. An ultrasound shows a cystic swelling with coarse internal echos in the infrahyoid midline location of the neck. Axial CT done at the same level shows a well-defined hypodense lesion with fat attenuation in the suprasternal midline location. A ranula is a rare, benign, acquired cystic lesion that occurs at the floor of the mouth as submandibular or minor salivary glands retention cysts. They present as a mass either in the floor of the mouth, where they elevate the mucosa, often with a bluish tinge, or in the neck. On ultrasound, ranula appears as a thin-walled cystic lesion and can be imaged both from the skin or transorally with a small probe. If infected, the walls are thicker and the fluid content more echogenic. On CT, they are seen as thin-walled cystic lesion with central fluid attenuation varying from 10 to 20 HU. If infected, the walls are thicker and the fluid is of higher attenuation. On MR, lower signal is seen on T1 and high signal on T2. This is a 14-year-old male who presented with painless swelling in the floor of the mouth since 4 years. Ultrasound shows a cystic lesion with fine internal echos at the floor of the mouth. Axial CT shows a hypodense, peripherally mildly enhancing, you could say, and with fluid attenuation in the floor of the mouth. A schwannoma is a benign tumor of Schwann cell origin and are the most common tumors of peripheral nerves and common posterior triangle masks. On ultrasound, they are seen as well circumscribed masses which displace adjacent structures without direct invasion. Cystic and fatty degeneration are common. The larger a schwannoma, the more likely it is to show heterogeneity because of cystic degeneration or hemorrhage. On CT, low to intermediate attenuation with intense enhancement may be seen. Small tumors typically demonstrate homogeneous enhancement and large tumors may show heterogeneous enhancement. CT shows a large heterodense mass lesion right side of the neck in the cervical region, and a sagittal CECT section shows a large heterodense mass lesion in the right cervical region. We can see the total extent of the mass on the coronal section. A cervical teratoma is a common neoplasm consisting of all the three germ cell layers. On ultrasound, solid and cystic structures with heterogeneous appearance and calcification appears more common than cartilage and bone formation. On CT, hypoattenuating thin-walled unilocular mass having heterogeneous appearance due to germ layers. This is a case of a cervical teratoma. On ultrasound, reveals a large heteroechoic lesion with solid and cystic components on right side of the neck. A contrast enhanced CT shows corner section with extension of the lesion and encasement of vessels and compression of trachea. A parotid lipoma may sometimes be seen. Head and neck lipomas in the pediatric population are rarely described in the literature, with only 25% of lipomas and their variants arising in the head and neck region. On ultrasound, well-defined hyperechoic lesion is seen involving the right parotid gland, and on CT, characteristically low dense lesion with HU value of fat may be seen in the parotid region. This is a patient of parotid lipoma, a 10-year-old male who presented with a painless swelling on right side of the neck since 2 years. Here on ultrasound, we show a hyperechoic lesion with well-defined margins in the right parotid gland, and on an axial CT shows a hypodense lesion with fat attenuation in the right parotid region. A rhabdomyosarcoma is an aggressive malignancy possibly originating from primitive mesenchymal cells that arise anywhere in the body, including sites where striate muscles are not found. It is the commonest pediatric soft tissue sarcoma, constituting 3 to 5% of all malignancies in childhood. On ultrasound, they are seen as heterogeneous hypoechoic lesion with ill-defined margins and internal vascularity. On CT, they are seen as heterodense lesions with ill-defined margins and show contrast enhancement. The lesion may also show areas of calcification. This is a child, 6-year-old male, who presented with a mass in the right paramedian location of neck since 2 years, and ultrasound shows an ill-defined hypoechoic lesion with internal vascularity. Axial non-contrast CT section shows the heterodense lesion with poorly defined margins. The lesion shows areas of necrosis and is displacing the airways mildly. Hemangiomas are benign vascular neoplasms that consist of hyperplastic endothelial cells, which is maximum in size during the first few years of life. On ultrasound, an echogenic mass with septations showing vascularity on color Doppler may be seen, and on CT, hemangiomas usually appear as enhancing mass that often contain calcified phlebolith. This is a child, 18-month-old female who presented with a painless swelling in the suboccipital region since birth, and ultrasound shows an ill-defined heteroechoic lesion showing both arterial and venous flow, and a CCT done shows an ill-defined lesion which is showing vascularity, intense vascularity in the suboccipital region. Ectopic thyroid tissue is a rare entity resulting from developmental defects at early stages of thyroid gland embryogenesis during its passage from the floor of the primitive foregut to its final pretracheal position. It is frequently found around the course of the thyroglossal duct or laterally in the neck, as well as in distant places such as the mediastinum and the subdiaphragmatic organs. On ultrasound, ectopic thyroid gland shows homogeneous hyperechoic appearance, and the capsule may appear as a thin hyperechoic line. On CT, the ectopic tissue is detected as variously sized homogeneous soft tissue at characteristic locations. This is a case of an ectopic thyroid in a 10-year-old male who presented with a painless swelling in the midline neck for the last 3 years, and the lesion was found to move with tongue protrusion. On ultrasound, it is seen as a well-defined hyperechoic lesion in the infrahyoid midline location of the neck. The thyroid tissue was absent in normal location. The CT done shows a hyperdense soft tissue mass with well-defined margins of the same attenuation as a normal thyroid tissue. Cervical abscess may be seen in children and in young adults, and the clinical symptoms and signs are often suggestive of the diagnosis. Imaging studies, including CT and MR imaging, are frequently required to confirm the diagnosis, but more importantly, to localize the infectious process and search for and delineate an abscess cavity. Ultrasound has also been found to be useful in the evaluation of superficial neck infections, especially to determine fluid accumulation. CT or MR images are valuable imaging tools to recognize early abscess formation and to map out the location and extent of the abscess. Such 7-year-old female who presented with painful swelling in the suboccipital region since 1 month. The ultrasound shows ill-defined hypoechoic lesion with coarse internal echos and thin septae which showed vascularity. Axial CT done shows thick-walled, poorly defined heterodense lesion showing areas of necrosis with fine septae. Branchial sinus. Branchial cysts, they represent swellings of the neck due to the remnant of the branchial cleft, which I have already discussed. When there is an opening in the skin, it is called a branchial cleft sinus. They can arise from remnants of the first, second or third branchial arches. Most of the branchial cysts are of second cleft origin, and they occur in the neck in the anterior border of the sternocleidomastoid muscle in the carotid triangle. Branchial cysts are said to be the second major cause of head and neck pathology in children and related to embryonic remnants of the thyroid and branchial structures. This is a child who presented with the sinus, an 11-year-old female with intermittent discharge from a small swelling on the right side of the neck. On CCT, we are able to see a hypodense sinus tract with peripheral rim enhancement anterior to the right sternocleidomastoid. Sagittal section shows that sinus tract is reaching up to the skin. Now, sometimes parathyroid adenomas may be seen in the neck, and they are benign tumors of the parathyroid gland and the most common cause of primary hyperparathyroidism. On ultrasound, homogeneously hypoechoic to the overlying thyroid gland, and echogenic thyroid capsule is seen separating the thyroid from the parathyroid. On CT, they demonstrate intense enhancement on arterial flow, washout of contrast on delayed phase, and low attenuation on non-contrast imaging. Here on axial CT, a 40-year 7-year-old female who presented with fracture shaft of right femur, and patient had history of joint pains for the last 8 months, and ultrasound was done which shows a hypoechoic well-defined lesion posterior to the right lobe of the thyroid gland. Axial CCT shows that the lesion is enhancing after contrast administration. Now we also did a study in our institute for evaluating neck masses for preoperative characterization based on location, extent, morphological characteristic and enhancement pattern, and to outline the extent in terms of involvement of the adjacent structures, vessels and possible lymphadenopathy. Surgical and histopathological correlation and FNAC where possible was done. 63 patients with clinically palpable neck masses were included in the study after detailed history and clinical examination. Ultrasound was done in all the patients and computed tomography and MRI were done as and when required. The final diagnosis was achieved by surgical findings, FNAC, histopathology or by follow-up. All patients who presented with clinical palpable neck masses were included. However, the exclusion criteria was the patient whom clinical palpable neck mass is diagnosed as lymph node on ultrasound or on histopathology, and patients whom palpable neck mass is diagnosed as thyroid mass in adults. Any contraindication to contrast agents, patients in acute or chronic renal failure, CECT or MR was not done. 63 patients were included in the age range of 5 days to 54 years, and the maximum number of patients were in the age group of 1 to 10 years, followed by 11 to 20 years, 21 to 30 and 0 to 1 year. 37 were males and 26 were females. Now the various clinical features were assessed. They were swelling size, consistency, whether solid or cystic. Most of the lesions were cystic. Whether the lesion moved with tongue protrusion, whether there was any skin discoloration or respiratory distress, pain or tenderness, and other associated lesions like lymphadenopathy, discharging sinus, joint pain or anorexia were also assessed. Maximum number of patients presented with duration of symptoms from 1 to 6 months, followed by 6 to 12 months, and less than 1 month was seen in 26.9% cases and more than 12 months in 14.3% cases. Ultrasound was done in all cases and correct diagnosis was achieved in 53 out of 63 cases. In comparison, CT MRI achieved correct diagnosis in 59 out of 63 cases. The diagnosis of neck masses on ultrasound were as listed below. They are thyroglossus cyst, which were 18 number of patients, true positive in 18 with a sensitivity of 100% and positive predictive value of 100%. Similarly, branchial cyst, 8 patients were seen, true positive in 7 and false positive in 2, with false negative in 1 and sensitivity of 87.5% and positive predictive value 77.7%. Similarly, lymphomangiomas were seen in 11 and true positive 11, sensitivity 100% and positive predictive value was 91.6 with a false positive of 1 patient. Ranula was seen in 5 patients, true positive 2 and false negative was seen in 3. Sensitivity was 40% and positive predictive value 100%. Dermoid cyst was seen in 4 and with the true positive in 2 and false positive 1. False negative was seen in 2 patients, a sensitivity of 50% and positive predictive value of 66.6%. Similarly, hemangiomas had a sensitivity and positive predictive value of 100%, mesenchymal lesions sensitivity of 50% and positive predictive value 66.6%. The other lesions, that is the ectopic thyroid, parathyroid lesions, branchial sinus and cervical abscess, all had sensitivity of 100% and positive predictive value of 100%. So, the sensitivity of ultrasound was 100% to diagnose thyroglossal cyst, lymphangioma, hemangioma, ectopic thyroid, parathyroid adenoma, branchial sinus and cervical abscess. Ultrasound was less sensitive in diagnosing branchial cyst, dermoid cyst, ranula and mesenchymal lesion. Positive predictive value of ultrasound was 100% for thyroglossal cyst, ranula, hemangioma, ectopic thyroid, parathyroid adenoma, branchial sinus and cervical abscess, while it was less for branchial cyst, lymphangioma, dermoid cyst and mesenchymal lesions. If we see the diagnosis of neck masses on CT, the thyroglossal cyst, lymphangioma, ranula, hemangioma, mesenchymal lesions, ectopic thyroid, parathyroid adenoma, germ cell tumors, branchial sinus and cervical abscess all had sensitivity and positive predictive value of 100%, while branchial cyst had a sensitivity of 87.5% and positive predictive value of 77.7%. Dermoid cyst had a positive predictive value of 50% and sensitivity of 50% and positive predictive value of 66.6%. So, final diagnosis that was achieved was cystic lesions were seen in 46 patients, mesenchymal in 4, thyroid in 1, parathyroid 2, vascular 5, neural 1, germ cell tumor 1 and other inflammatory lesions like abscess and branchial sinus were seen in 2 patients and 1 patient respectively. Thank you.